Good morning, ma'am. Welcome to Treat DM 2025. Myself, Dr. Prakash from Diacon Hospital, and this is Dr. Bhavana Sosale, Director and Consultant Diabetologist, Diacon Hospital, Bengaluru. Ma'am, today your topic is MR antagonist, finerenone in CKD. Here is a question for you. A great drug, at what stage do we use it and after what drug? We are using already SGLT2 inhibitors, ARBs and ACE already. Should we start this as a third drug or early?
Thank you, Dr. Prakash. That's a wonderful question that many of us face as clinicians. Mineralocorticoid receptor antagonists are one of the pillars of management of CKD. So we have a couple of drugs which form different pillars. As you mentioned just now, SGLT2 inhibitors form one pillar. RAS blockers, ACE inhibitors or ARBs, they are the second. The third now is mineralocorticoid receptor antagonists like finerenone, and we also have data with GLP-1 receptor antagonists. So when to use it? That was your question.
Yes, ma'am.
So the standard of care for many years has been ACE and ARBs. So those were the first drugs that came into clinical practice, and all the trials are based on that. The next set of therapy that showed evidence in preventing progression of CKD and improving albuminuria were the group of drugs called SGLT2 inhibitors. So now we have data with both empagliflozin and apagliflozin in CKD. More recent years, we also have data with finerenone from a set of trials called the Fidelity group of trials. And this has shown reduction in albuminuria and improvement in CKD outcomes in patients at different stages of CKD, but predominantly people who have albuminuria. So this has not been studied in those with no albuminuria, or the evidence is very minimal. So we still feel that ACE or ARB plus SGLT2 inhibitors are going to be standard of care. And over and above that, when someone still has albuminuria, which is not controlled, we think of adding an agent like finerenone. If someone can afford, a GLP-1 RA should be on as well. So,
that is the wonderful response. What is your opinion on Treat DM 2025, ma'am?
I think this is going to be a new platform for doctors and scientists to come together. Now, there are always gaps in medicine that the scientific community will not truly know about or be aware about, but they are the ones actually working on the bench to bring out solutions which come into life and make a difference to patient care. Maybe not immediately, it could be a decade from now, maybe 2 decades from now. But this is what science is all about, of having discussions, thinking of problems, and then finding solutions together. That is what the clinical community needs to do more often. And we have to acknowledge that this is where the real solutions begin.
Thank you for your insights, ma'am. Good morning.
Thank you.